Hello and welcome. Today we're diving deep into a really critical challenge in modern medicine, line sepsis. We're going to explore how central lines, these absolute lifelines for so many patients, can paradoxically become the source of a life-threatening infection.
So here's our roadmap. We'll start by defining the key syndromes. Then we'll get into the detective work, the diagnostics and pathogen ID. After that, we'll look at the culprits themselves, the treatment arsenal we have, and some crucial prevention strategies. We'll wrap up with the serious consequences and a quick knowledge check to make sure it all sticks.
All right, let's start at the beginning. To really understand the problem, we first need to have a rock-solid grasp of what we're talking about when we say sepsis, and, more specifically, a catheter-related bloodstream infection. Okay, so what is sepsis, really? Well, it's not the infection itself that's the main problem. The real danger is the body's response to the infection. It's a chaotic, dysregulated, and frankly self-destructive inflammatory cascade that leads to organ dysfunction. And that's what makes it a full-blown medical emergency.
And just to put this into perspective, the mortality rate for sepsis is absolutely staggering, somewhere between 30 and 50%. A number like that really drives home why every single minute matters when you're diagnosing and treating it.
Now, you have to think of sepsis as being on a spectrum. When that dysregulated response spirals even further, it can progress into what we call septic shock. And this isn't a vague clinical impression. It's defined by very specific hard numbers. We're talking about persistent low blood pressure that doesn't respond to fluids, so you need vasopressors to keep the organs perfused, and a rising lactate level, which is a clear signal that the body's cells are starving for oxygen.
So this brings us to CLABSI, a central line-associated bloodstream infection. This is when we can pin the blame for sepsis directly on a catheter. The criteria here are really strict. You need a laboratory-confirmed infection. The central line had to be in place within the 48 hours before the infection started, and, this is crucial, there's no other obvious source. The line itself becomes the prime suspect.
So, how do we prove it? This brings us to the investigation. Moving from suspicion to a confirmed diagnosis is all about meticulous lab work, getting the right cultures, and identifying the pathogen.
The whole diagnostic process is designed to prove causation, not just correlation. It all starts with a clinical suspicion. You know, the patient has a fever, chills, maybe their blood pressure's dropping. But to really nail the diagnosis, you need microbiological proof. This means taking two key samples. One blood culture from a peripheral vein, far away from the catheter, and another culture from the very tip of the catheter once it's removed. When the exact same bug grows in both cultures, that's your smoking gun.
Okay, we know how to find them, but who are we actually looking for? Let's talk about the usual suspects behind these infections and the ever-present growing challenge of antimicrobial resistance.
You're often going to see a familiar cast of characters. Skin bacteria like Staphylococcus aureus are a huge one, since they can literally crawl from the insertion site down the catheter track. Then you have your classic hospital-acquired organisms like Pseudomonas and Enterococcus, which are notorious for forming these tough, resilient biofilms on medical devices. And of course, you can't forget gut bacteria like E. coli and Klebsiella, especially in critically ill patients with other underlying issues.
You know, talking about resistance always reminds me of a bit of dark microbiology humor. What do you call a bacterium that's resistant to all antibiotics? Very lonely, because nothing else can live near it. It's a joke, but it perfectly captures the terrifying reality we're up against when trying to pick a treatment.
So, with that in mind, let's dive into the arsenal. How do we fight back? This part's all about our therapeutic strategies, highlighting the difference between empirical therapy, which is our best initial guess, and targeted therapy once we know exactly what we're fighting.
You know, successful treatment starts with a really educated guess. That's what we call empirical therapy. It's guided by the clinical picture. So, if you think the source is abdominal, you'll choose an antibiotic that covers common gut flora. But if you have a patient at high risk for a superbug, say an ESBL producer, you have to bring out the big guns right away. You escalate to a broad-spectrum agent like a carbapenem to make sure you're not falling behind. This kind of clinical reasoning is absolutely vital for patient survival.
Of course, even with a great arsenal, the real win is never having to use it. This brings us to prevention, where we'll talk about proactive measures we can take especially for our most vulnerable patients.
You know, modern infection control isn't just about one single action anymore. It's about using a bundle approach. This is basically a checklist of evidence-based steps that, when you do them all together, have a massive impact on reducing infection rates. We're talking about everything from pre-op antibiotics and S. aureus decolonization all the way to tight blood sugar control. It's all about building multiple layers of defense.
Prevention also means thinking bigger. For instance, an invasive group A strep infection isn't just a problem for the patient, it's a notifiable disease that triggers a public health response. And in kids, the game is different. Certain bugs, like some strains of E. coli, carry unique and devastating risks, like causing hemolytic uremic syndrome, or HUS, which can lead to acute kidney failure.
So this leads us right into the potential fallout when these infections spiral out of control. And then we'll have a chance to solidify what we've learned with a couple of questions.
When a CLABSI isn't contained, the consequences can be devastating. The bloodstream becomes a highway for the infection to seed itself in other parts of the body. This can cause endocarditis, an infection of the heart valves, or osteomyelitis, a bone infection that's notoriously hard to treat. And any foreign material, like a prosthetic joint, becomes a magnet for infection. A simple line infection can quickly become a systemic catastrophe.
All right, time for our first knowledge check. Think back to the diagnostic process we talked about. What's the one thing you absolutely must have to make a definitive CLABSI diagnosis?
The correct answer here is B. Clinical signs like a fever just aren't enough on their own. The definitive diagnosis of a CLABSI hinges on the microbiology. You have to isolate the exact same organism from both a peripheral blood draw and the catheter tip. That two-site confirmation is what links the line to the infection.
Okay, question number 2. This one's all about clinical decision-making. Your patient is septic, and you know they have risk factors for an ESBL-producing organism. What antibiotic class are you reaching for as your first-line empirical choice?
And the answer is C, a carbapenem. Look, when you have a high suspicion for an ESBL, you cannot afford to be wrong with your initial therapy. Carbapenems give you that reliable, broad-spectrum coverage against these highly resistant bacteria, which is why they are the standard of care in this high-stakes situation.
And for our final question, you've identified an invasive group A strep infection in your patient. What does this mean beyond treating them? What is the key public health consideration here?
The correct answer is B. Invasive group A strep is an individually notifiable disease. This isn't just paperwork. It sets a public health response in motion. This might involve increased surveillance or even recommending preventative antibiotics for close household contacts to stop the chain of transmission. It's a perfect example of how the bedside connects to the broader community's health.
And that leaves us with a final and pretty sobering thought. As antimicrobial resistance continues to escalate, maybe our ability to win the war on sepsis won't come from new drugs. Perhaps the real final frontier is diagnostic speed, our ability to identify the enemy faster and with more precision than ever before. Thank you for joining me for this explainer.